My talk for today is first line treatment options in metastatic hormone sensitive prostate cancer. At the outset, let me thank the organizers for giving me this opportunity to speak today. Starting with the topic, we do know that hormone sensitive metastatic prostate cancer is an incurable disease, and unfortunately, majority of the prostate cancer in our country and in this region, they present in this advanced stage of disease. The median survival of these patients in general is around 2 to 3 years, with hormone therapy alone, which has been the backbone of the treatment for this disease till recently. And it remains so also now. But let us see how far we have improved upon beyond this, as hormone therapy will be talked about separately. So I won't be talking a lot more on hormone therapy, that is the first line hormone therapy in this setting, which is the backbone. Starting with chemohormonal therapy, so there are pros and cons, and I need to concede that when I was getting trained, I didn't think that chemotherapy can be one of the treatment options in prostate cancer, and that too very effective. But they did have pros and cons. The pros: it attacks de novo testosterone independent clones early. Some patients are too frail at the time of progressive disease, so if you give early, it is better. No continuous daily intake of tablets required, that is for compliance, and metabolic complications of long term of steroid is not there. But there are cons also for chemohormonal therapy. ADT will take cells out of the cycle and be less responsive to cytotoxic chemotherapy theoretically. Some patients respond to ADT alone for a long time and might not need chemotherapy. And chemotherapy has toxicities, and that all medical oncologists are aware of. But yes, there were some courageous people who designed this study. This was hormone sensitive prostate cancer, which was stratified for METs, age, performance status, combined androgen blockade, SRE prevention, and prior adjuvant therapy to give patients docetaxel or plus ADT versus only ADT, and then to evaluate them for the endpoints. That was to see that what happens for progression-free survival and what happens to overall survival in these patients. What this trial showed, and which was a surprise for everybody, that it remarkably improves overall survival in these patients overall. And if we break them in high volume and low volume disease, then the effect on high volume remains significant, and in low volume remains there was a trend towards overall survival improvement, but it was not statistically significant. But that was the subgroup analysis in this study. And when we see the quantum of benefit, the median improvement in survival in these patients who received this chemotherapy was around 13 months plus. That was absolute improvement in survival, with p-value being 0.0003. And if we see this in the high volume disease, then the absolute improvement in survival was around 17 months, which is by and large almost unheard of in most of the tumor in metastatic setting. So this was a significant improvement in outcome if chemotherapy being added to the baseline hormonal therapy in advanced prostate cancer. Now, what was the definition of high volume disease? That becomes important when we want to decide the treatment in the clinic, especially in this study. These were the patients who had the visceral metastasis disease, 4 or more bone mets lesions, and with one being in the vertebral body and the pelvis. And that may help us in decision making. And these were the inclusion criteria for patients for this study. We do know chemotherapy does have toxicity, and what we can see here in this trial, yes, they did have toxicity, but toxicity was very reassuring. There were hardly patients, and they were in single digits, who had grade 4 toxicities. And if we take grade 3 and grade 4 together, then only few patients had febrile neutropenia, which we are very concerned about when we give chemotherapy in any situation, and especially in elderly population. We are highlighting the impact of the outcome in this different subgroup, and what we can see here that almost all subgroup, there were a similar benefit if the docetaxel was given. Subsequently, there was another study which was ongoing, which had the result which was out, and here it was standard of care, that is ADT, was compared to docetaxel combination in two forms. And what we see here, this was a good number of patients, almost 2,962 patients, which were randomized in the four arms. And when the docetaxel versus standard therapy was compared, one of the important things to remember in these patients were that the high-risk inclusion criteria in these patients were different from what we had seen in the chartered study. They were the patients who had the Gleason, who had T3, T4 tumor, Gleason score 8 to 10, and PSA being 40 and more in this situation. So at this moment, you do have differences in high-risk group of patients, but what we see in these patients that median overall survival improved in this trial also, and it was significant. It improved from 67 to 72, and the hazard ratio was 0.81. And same was also true for FFS in these patients, which again improved by around 16 months in these patients, with hazard ratio being 0.62. So the message with Stampede study was the improvement in survival across a population of men with metastatic high-risk, castrator-sensitive prostate cancer commencing first-line long-term hormonal therapy through the addition of docetaxel chemotherapy, but not by adding zoledronate. So it answered the question that adding docetaxel was beneficial, what we also saw in the chartered study. Sure, when we have multiple studies, we do meta-analysis. Here also meta-analysis was done by combining the various trials which was done at that time for docetaxel in hormone-sensitive prostate cancer. And what was observed that if you add docetaxel to these patients, then overall survival does improve, with the hazard ratio being 0.77, which translates in the absolute improvement in survival at 4 years of around 9%. And just to remind people that 9% absolute improvement in survival is significant in almost any situation. It also improved FFS with hazard ratio 0.64, which translated in absolute reduction in 4-year failure-free survival of around 16%, which was again important. But there are barriers to use of chemotherapy. Advanced age of the patient in prostate cancer, poor performance status in significant proportion of patients, coexisting illness, patient preferences, they do fear chemotherapy, and chances of grade 3 specific toxicity like pneumonitis, febrile neutropenia, and neuropathy. There has been many retrospective analysis which does highlight this issue when we treat the patients with docetaxel in advanced stage prostate cancer. Subsequently, people did try to explore, can we have some alternative in this situation? And what they did, they tried to see, apart from the background hormonal therapy, can we add a more hormonal therapy in this setting to improve outcome? And what was the rationale? The rationale was that if you give the baseline ADT, then the blockade for androgen production happens from the testis. But androgen still drives prostate cancer by synthesis of androgen by adrenal gland, intratumoral production, or aberrant androgen receptor. The CYP17 enzyme, this is a key enzyme in androgen production, which is there, and it was thought that if you block this enzyme, then maybe combining one hormone therapy with another hormone therapy may improve outcome. This was one of the initial studies, which in advanced prostate cancer compared abiraterone with baseline ADT versus ADT plus placebo in these patients. Here the abiraterone dose was 1000 milligram per day. Primary endpoint was overall survival and radiographic progression-free survival. And there was secondary endpoint of PPS, then toxicity, the quality of life, and skeletal events. In this high-risk prostate cancer, the metastatic and high-risk prostate cancer that is metastatic, the definition was that the patients who had the Gleason score 8 or more, at least 3 bone lesions, and the presence of multiple visceral metastasis. Again, highlighting that in different trials, people have taken different criteria to define what do we call high risk disease in advanced prostate cancer. These were the results. The progression-free survival was better, and also the overall survival was better. And what we see, the hazard ratio of 0.62, suggesting that if we give the patient abiraterone plus the baseline ADT, then the risk of decrease in death is almost 38% in these patients. That is the relative risk, decrease in the risk of death in these patients, which is again statistically significant with p-value being 0.001, and that was less than this. So what was the highlight of this study? That is called latitude study. The median overall survival was better in patients receiving abiraterone. Overall survival at 3 years was 70% versus 50%. That is absolute improvement of survival of 20%. Radiographic PFS was 33 months versus 14.8 months. And there were some important adverse events like grade 3, grade 4 hypertension. It was 20% versus 11%, and grade 3, grade 4 hypokalemia, that is 11% versus 1%, which is again reminding that these were tablets. We consider them safer, but they do have some side effects which can be potentially troubling and sometimes life-threatening. These are the subgroup analysis for progression-free survival in the same study, and it highlights that by and large, almost every subgroup had a similar benefit if this drug was given to these patients. There was also a study that was Stampede study, in which arm G, that is 2017, there was a group of patients who were given ADT, and there was a group of patients who were given ADT plus abiraterone. And this was the analysis for that study. And what we see here, that in this study also, if abiraterone was added to baseline ADT, then there was a significant improvement in survival in patients receiving abiraterone plus baseline ADT as compared to the patients receiving only ADT, which confirms the finding what we had for in the previous trial, that was a latitude study. This highlights that 3-year overall survival was 83% versus 76% in favor of patients receiving abiraterone as compared to patients receiving only ADT in this study. 3-year failure-free survival was 75% versus 45%. Again, a very significant improvement in control of disease in these patients with hazard ratio of 0.29 with p-value being less than 0.001. As I said, when you have multiple study, you do meta-analysis, and here again meta-analysis was done for abiraterone-based trial. And what we observe here, that if in this meta-analysis also, the overall survival and progression-free survival was better for patients receiving ADT plus abiraterone as compared to ADT alone in these group of patients. So what we can infer for this from this meta-analysis, that there was 38% reduction in risk of death with abiraterone combination with ADT, which translate in absolute improvement in survival of around 14% at 3 years in these group of patients. There was also a 55% reduction in the risk of clinical and radiological progression, which translates into 28% absolute improvement in the decrease in the risk of clinical and radiological progression at 3 years, suggesting that yes, this drug is useful in this setting. But it also suggested that there is a threefold increase in grade 3, grade 4 acute cardiac event and hepatic toxicity in these patients if abiraterone was given, reminding that yes, this drug is oral tablet, but it has its own toxicity. Subsequently, another hormonal therapy, that is enzalutamide, was also tested in this situation, which worked in castrate-resistant prostate cancer. So it was tried in castrate-sensitive prostate cancer. And what we see here, a randomized trial with a good number of patients, more than 1,000 patients, were randomized between enzalutamide plus ADT versus ADT alone, with the primary endpoint of overall survival. They had a secondary endpoint of PSA PFS, the clinical PFS, AEs, and quality of life analysis. These were the baseline characteristics, which appears to be fairly matched between the two arms. And this is the primary endpoint, that is the overall survival. And what we can see here, that overall survival improved from 72% to 80% with a hazard ratio of 0.67 with p-value being 0.002. What I want to highlight, remember This is 3 year survival of around 80% in enzalutamide arm, and highlighting this is the kind of survival what we see in almost stage 1 and 2 patients in lung cancer. And this is what we are seeing in prostate cancer, advanced stage disease, with the newer kind of therapy, which pushes the bar up as far as the outcome is concerned in these patients. This is the data for progression-free survival for the PSA, that is the time to PSA increase, and the clinical progression or death. And here it is time to clinical progression in this second curve. And both the situation, what we can see that enzalutamide fared better in both the situation, and it looks like it was statistically and also appears clinically relevant data. There was a subgroup analysis for the same study, and what we can see here that almost every setting it appears that enzalutamide fared better than only ADT. But there are concerns with enzalutamide, so there is a concern with almost any treatment. It does have more side effects as compared to ADT alone, and there are some of the side effects like seizure, delirium, which is specific for this drug, which we need to be aware of when this drug is being prescribed to our patients. Now, what are the constraints with hormonal therapy? Because these are tablets. One of the concerns is the prolonged duration of therapy as compared to fixed 6 cycles of chemotherapy. When we give tablet, there's the issue regarding compliance and adherence to the treatment what we give. We also do know if we give 6 cycles of docetaxel, it ends at that time. But here the tablet goes on and on for years altogether. So this does leads to financial toxicity, especially in the country like ours and in the region like ours. There is a long-term metabolic complication for these treatments like diabetes, hypertension, cardiovascular disease, bone mineral density loss, osteoporosis with abiraterone, which we need to remember when we prescribe this drug that it is oral tablet, but it has its own problem. There are also specific risk factors like seizure disorder, delirium, history of fall in elderly population if they receive enzalutamide, again oral tablet, and also financial issue with these tablets because this now also remains expensive, more expensive as compared to in fact abiraterone, and again one needs to give it for years altogether. There has been indirect comparison for these two approaches, that is docetaxel versus abiraterone in hormone-sensitive prostate cancer. And it appears that the 14% absolute improvement in 3 years overall survival with abiraterone as compared to 8% with docetaxel. In both studies, incidence of any AE leading to treatment discontinuation or death was similar between the two arms. This is one of the network meta-analysis, and what they concluded that in indirect comparison, either we give abiraterone or we give docetaxel, there was no statistical significant difference in overall survival. But it does appear that in this model, there is a high chance that people may choose abiraterone for treatment as compared to docetaxel. But again, we need to remember this is network meta-analysis. There is another network meta-analysis, which once you don't have a direct comparison, we do many of those kind of analysis, and what it suggests again that maybe the tablet is better than injections as compared to injections, especially when we want to maintain quality of life in these patients. But again, I need to highlight these data is from Western world, especially in the context of the financial toxicity and the compliance issue in our region. I'm not sure this will be exactly reproducible in our setting. But having said that, this is the data which is available. We also need to remember when you have these two options, docetaxel versus hormone therapy option, then this can be one of those ways of deciding which one we want to choose. What we know that if you do have ARV7 mutation, then it appears they don't respond to hormonal therapy in this setting. So in these patients, it is maybe better to give docetaxel as compared to giving hormonal therapy. There's no randomized trial as on date, but with this data available, it is intuitive that maybe this is the way we may choose the treatment for our patients. We also look into what is the real world data. This appears that our concern regarding toxicity of docetaxel remains higher when we see the real world data. And what we can see here, that if we use docetaxel in these patients in the real world, then the toxicity is higher in these patients, and that may be primarily because of the liberal use of docetaxel in this situation as compared to what we see in in the trial, the kind of patients we choose. But this highlights that we need to be a bit careful when we use chemotherapy in this setting. It's again highlighting another study which compared with a trial that neutropenia was around 45% as compared to 12% what was seen in the trial. Febrile neutropenia was 12.5% as compared to 6% what was seen in the chartered study, highlighting that you do have more toxicity in the real world data. We also do have in real world data some kind of toxicity which we don't see in trial much. This is docetaxel induced lung injury, which happens in around 3 to 5% of these patients who receive docetaxel. There are now some concerns regarding docetaxel leading to some fatalities, and one needs to be concerned about it when we take a decision regarding using the treatment. This is the probable algorithm for choosing our patients, how we are going to treat them in the clinic. So if you have a castrate sensitive prostate cancer, if there's a high burden disease, patient is fit for chemotherapy, good to give chemotherapy plus ADT. If patient is unfit for chemotherapy and patient preference is against chemotherapy, high risk disease or low volume disease, then it may be good idea to use one of the hormonal therapy that is abiraterone plus enzalutamide and combine with ADT. This is the ASCO 2021 update for metastatic castrate-sensitive prostate cancer, highlighting the same which we discussed just some time back. That if you have a high volume disease, if patient is fit, maybe it's good to choose chemotherapy plus ATT. If it is not a no, high volume disease, then maybe hormonal therapy may be a better option. So what is the key for deciding the and choosing the patient? It is choosing wisely and also staying safe. So this is not only true for in Corona or COVID era. This is also true. It is also useful, always that when we choose treatment for our patients. I thank you all for listening.